Thank you everyone for joining us today. The CTSC welcomes you to this month's Science Cafe. So for those of you who are not familiar, the Clinical and Translational Science Collaborative of Northern Ohio is a collaborative among Case Western Reserve University and the affiliated partners that include Cleveland Clinic, Metro Health, University Hospitals, VA Northeast Ohio Health System, NeoMed, and then the University of Toledo. And so just briefly, the CTSC aspires to be a catalyst for high quality clinical and translational science, as well as transformative research to positively impact the health of those in Northern Ohio and beyond. And so we've only had one Science Cafe so far. So the goal of these sessions really is to gather scientists, investigators, trainees, and community members that have common research interests with hopes of them all forming new collaborations. So today our session focuses on artificial intelligence in research, and we have with us Dr. Kaelber and Dr. Shu. So a little bit about both of them. So Dr. Kaelber is the Chief Health Informatics Officer at Metro Health, as well as a professor in internal medicine, pediatrics, and population and quantitative health sciences at Case Western Reserve. He also directs the Metro Health Systems Center for Clinical Informatics Research and Education, and he also serves as the informatics lead for the CTSC. Dr. Kaelber's research focuses on applied clinical informatics, specifically electronic health records, personal health records, clinical decision support, big data, telemedicine, and the use of electronic health records for chronic disease detection and management. And along with Dr. Kaelber, we also have joining us Dr. Shu, who's a professor for biomedical informatics, and she also is the director for the Center for AI and Drug Discovery for the School of Medicine at Case Western Reserve. Dr. Shu's research focuses on facilitating biomedical discovery and improving healthcare delivery by promoting efficient biomedical knowledge flow among biomedical researchers, physicians, and patients. And so with that, I will turn it over to both of you. Thank you so much for joining us today.
Great. Well, wonderful to be here. I think I'll probably go ahead and get us kicked off if that's okay, Rong, and then you can join in. And I think the format is, I probably will talk for 10-ish minutes. We could have some discussion after that, or maybe it makes sense to have, Dr. Zhu, present as well. Again, probably for like 10 minutes, but hopefully most of the time will be spent, actually, hopefully what we say will stimulate some discussion. Among everybody gathered here. Science Cafe, AI and Research. So just to try to do some framing, what do we think the promise of AI is? And, is AI new or is it not so new? And so I'll try to frame that in some of the work that I've been doing that hopefully other people can. I will lay down a challenge that I think we have a unique opportunity in Northeast Ohio in a particular area of AI research. But let's get into this. So this actually came from another talk I was at. It's quoting a professor at Harvard Business School, where AI is not going to replace humans, but humans with AI are going to replace humans without AI. But I'd say a lot of the work that I'm thinking about in the AI space, again, being in the Metro Health system, is again, not that we're going to be sort of getting rid of people, so to speak, but that people are going to be able to be much more efficient, whether it be a patient, a provider, other staff, with the appropriate use of specific AI tools. This is also another slide I really like from the Epic Corporation, but I think this is very akin to other people that I've been talking with and how they sort of think about the AI space. And I would sort of point you to the lower right-hand corner. I think there's so much buzz about AI in the last 6 months or so, really because of the generative AI space. So, right, the generative AI we're talking about here is like these large language models. You can think Chat GPT, all the things that we've heard in the news about over, again, say like the last 6 months. But I think it's very interesting about this slide is that you really, I think for those of us in the field for a while, generative AI is just sort of that next version of a whole slew of artificial intelligence algorithms that we've been using really for a long, long time. You can think, like neural nets, in the learning deterministic space in the middle, predictive models, and then even predefined deterministic artificial intelligence in terms of calculators, evidence-based clinical decision support, rules-based logic. And again, I would just say from my own view, thinking of my own work and research and what's happening in Metro, we've really been doing AI for decades at this point. Yes, the probabilistic artificial intelligence around generative AI, that's new. That's probably 6 to 12 months old at this point. But we've been doing predictive modeling, at Metro for getting close to a decade now. And since we first turned on our Epic electronic health record in 1999, we were already doing a bunch of calculators and rule-based logic that was having significant improvements in care. So I think sort of framing that larger picture is important. I'll just go through a lot of these quickly, knowing that we can have time later in the cafe to talk more about them. But this is really where I want to sort of lay down the gauntlet. So this is actually a slide from a person I had give grand rounds on artificial intelligence last Friday. And he had cited this article looking at the scholarly activity around research for AI. And so first of all, this emphasizes my point that people have been doing research in this space for many decades now. I think what's striking here, though, is that so much of this research is in model prototyping and sort of model development. And it doesn't, if we sort of think about that bench to bedside or even, cell to bedside, it's really focused on the equivalent of the cell or bench piece and isn't really focused much on some of the workflow integration and clinical outcome evaluation. So, I mean, to me, and I'll revisit this again, but this seems like the huge opportunity for us at Case Western in the Northern Ohio CTSC, because not only do we have great, sort of theoretical folks doing things and skill sets in AI, but then we have amazing healthcare systems where we can actually take the AI and try to do something that's actually going to make those clinical people or other people in a healthcare system not get rid of them, but they're going to be much more powerful than their equivalents without AI. So think about this slide. I'll come back to it at the end. Just go through these really quickly. We've had rule-based alerts, for instance, for diabetes care going back decades now. We've published in the New England Journal of Medicine about how electronic health records through some of the rule-based AI can really improve diabetes care. We've shown that we can avert amputations. We've shown that we can eliminate the racial ethnic gap in diabetes care. All of this work was published and completed, 10 to 15 years ago, but extensive opportunities that were leveraged in rules-based AI. And I think there's a lot more work that can be done there as well. So I was looking for opportunities to help folks there and create new partnerships. We're very centered on the Epic electronic health record, like all of the healthcare systems in the CTSC are at this point in Northern Ohio. And the Epic Corporation spent a lot of time over the last decade developing predictive models. And then, of course, to me, I always tell my team, predictive model is only as good as the workflow that when you wrap around the predictive model can make the predictive model wrong, right? So the idea is if someone's predicted to have sepsis, then because of a workflow that you're wrapping around the predictive model, you do something to decrease the chance that that person has sepsis. So we've been a big leader in this space, developed implemented a number of Epic predictive models. And Epic Axel has the ability now so that if anybody has their own idea of a predictive model, that can be wrapped into the Epic electronic health record with the appropriate workflows. We published a bunch on this. So if anybody wants, we published in a critical care medicine a sepsis predictive model. And the highlight is really there in red at the bottom. So in the sepsis predictive model patients, when we had the alert showing that they were likely to get septic, we administered antibiotics 30 minutes earlier, and the days alive and out of the hospital were 24.1 out of 28, as opposed to 22.5, which was statistically significant. But again, it also sort of speaks to the idea of, what did the AI do? It allowed antibiotics to be given a little bit earlier, and it allowed, 2 days earlier or more people to be alive and out of the hospital. So it definitely helps, but it didn't sort of eliminate sepsis. We also published last year the no-show model, where we showed that, again, the appropriate workflow wrapped around our no-show model decreased no-show rates by 8% overall, and specifically decreased it by 15% in Black patients. So really helped eliminate the disparities in no-shows from a racial ethnic perspective. These are a whole bunch of different ways that we're leveraging AI through our Epic electronic health record. Everything in green are things we're doing. Everything in black are things we could be doing. I'll just point out again, hopefully I can explain to this audience, the column on the right, actually the biggest workflow improvements, even though they're small, are in all these things that, again, you're probably already seeing in your phone or in your email, where you type something, AI is helping you finish the sentence, so to speak. So those are the types of things, those workflow models on the right, where even though the individual improvement is small, maybe second or even fraction of a second, because it's helping our staff thousands or tens of thousands a day, it really makes a significant impact. But I think there's opportunities not only to think about sort of traditional AI predictive models, but think about some of these workflow impacts as well. Again, I won't go into a ton of details with this, but this just gives us all the sense of the Epic Corporation roadmap for thinking about all of the generative AI. Now we're moving into the generative AI space. And I would say any of these is ripe for an evaluation and an improvement, which we'd love to partner with folks on. We're currently working on augmented response technology for when patients send us messages through the personal health record portal, and trying to automate for the provider the response back. So an example of this is a patient saying, hey, I have a rash that's been spreading on my arm for the past week. It's itchy. I'm getting concerned that it's not going away. What should I do? And so this is the idea of the generative AI responses. Dear Haley, the patient, I'm sorry to hear about your rash. As it's been persisting for over a week, it would be best to have it be examined. Please schedule an appointment at your earliest convenience so that we can take a closer look and discuss your symptoms in more detail. So again, that was all generative AI developed. And then the provider, again, we're assisting the provider. We're not eliminating the provider. The provider can either start with that draft and tweak it, or if they don't like that message, start with a blank. This is just another example. We want to be very transparent where we're going to put this moniker that says that it was generated automatically and reviewed by a provider. We have a whole plan within the Metro system to be rolling this out over the next several months here. Love if anybody is interested in partnering with us to help evaluate this. We'd love to do that. I think it's interesting to think about what success means for this. So we've looked at University of California, San Diego. Already did a little bit of work in this area and showed that actually the time spent with the composing a message back to the patient is about the same whether you had the automated response or did it yourself. The large language model or generative AI responses were much longer than the typical responses from a provider. And the real win was significant improvement in clinician satisfaction because of less cognitive load that they needed to spend composing the message. And the patients actually thought that the AI-generated messages were more empathetic than the provider-generated messages because presumably the provider is just not taking as much time. We're also looking at clinical summaries as another big win because particularly now we have 25 years of electronic health record data. So if you're a new provider coming into the patient's chart, very hard to understand what's going on with the patient quickly. So we've got clinical summaries that hopefully we'll be doing by the end of the year. They can be specially specific. In this example, you can understand why a vascular surgeon might be interested in different information than a primary care provider like myself. These are more just details. I won't go through them here, about what are all the things that we could be doing with AI within our electronic health record today. And I'll just spend like 2 more minutes talking about Cosmos. So I think this is another huge tool that we have access to in the CWRE community, where we've really collected over 240 million patients worth of data, all put them in a repository, sort of I guess you call like a data lake, potentially even, where, with the right training and credentialing, you can log in. And again, to me, it's the biggest electronic database of patients in the world. Won't go through this for the sake of time. A lot of healthcare systems are contributing, including non-academic medical centers, which I think is very interesting with this whole idea that, most research is done on people at academic medical centers, and that might not be representative of of people in care at non-academic medical centers. We just passed 243 million people in Cosmos. The data in Cosmos is very representative of the US Census in terms of some of this demographic information. These are some of the information that you can get through Cosmos. Again, if anybody wants more details, we can talk about it later on. We've published with this, if anybody wants to look at this publication, but to me, it's the largest set that I know of de-identified patient-level data in the world. And so it should be an amazing opportunity or area to create and test AI models. So again, I go back to this slide. How could we work together? Maybe in the model prototyping and model development through something like Cosmos, but more in these areas like 6 or even 7 and 8. And so when we get to the discussion, I'll plant these now and then turn it over to Rong. Really want to hear what other people are doing in AI today, what other people are planning to do. And then number 3 is sort of like my challenge. What would it take for the CWRE community with our associated healthcare systems to become or even the leader in workflow integration and clinical outcome evaluation of AI? And then I always think about, we're spending an hour of our time together. So can we come up with, by the end of this, one thing that we would do differently because of our time spent together? So with that, I'll turn it over to Rong.
I'm just probably slightly different from Dr. Kaelber's topic about the AI. He's more focused on AI using clinical setting, predictive AI to improve workflow. So I'm most talking about how AI can be used for biomedical discovery and enable research. So I'm a director of the Center for AI in Drug Discovery. Even though the center is about the drug discovery, but we heavily focus on novel AI algorithm development. And for drug discovery, of course, we need the first understanding disease mechanism. And we do drug discovery, precision medicine. We want to see which drug work in which population, and also the outcomes research. And we are also very interested in environmental health, health policy, pandemics. Basically, we are interested in everything related to biomedical research, and the goal is to improve human health. So we work in collaborate with bench scientists and also clinicians. We very focus on education. We trained about dozens of medical students and high school students. We're also interested in commercialize the drug candidates. So probably you already talk about a lot of like generative AI, deep learning, AI, like data-driven models. So what we are trying to do is slightly different. So we are trying to develop an algorithm to mimic how biomedical researchers come up a novel hypothesis. So it's not just a prediction and classify yes or no. So we really want to say, come up with hypothesis. And then we work closely with domain experts and to refine those hypotheses and then test those hypotheses in mouse models or in patients. So in order to do this, we really need a develop algorithm to extract the semantic knowledge, not just data, knowledge from all different resources, including like 36 million published articles, the database, the patient electronic health record. So we use natural language processing, machine learning, knowledge engineering approach to extract the knowledge from all those data resources and integrate those knowledge. And so basically we thought in order for the AI algorithm to make those discovery, first you need to have a big brain, means knowledge center, not just data, you need to have a brain. So it means knowledge. And then because for drug discovery, we close work with domain experts like scientists. So we really need to explain to them, say, you predict some drug candidate. We want to explain, say, how this candidate come and how your algorithm predict it, how this is related, make biological sense. So we develop AI algorithm is knowledge driven and also explainable and transparent. Basically, we predict a candidate. We can explain say how this candidate is drug candidate related to the disease. We can step by step explain those predictions. So we have been working, I just said, working drug discovery, disease mechanism understanding. We also diagnosis, precision medicine, even gut microbiome, environment, and pandemic. Basically, is from genes, molecular, cellular, patient to the whole population levels. I just use one example. Recently, we did so. We developed AI algorithm, combined the AI algorithm and the human intelligence and the patient electronic health record-based testing, and also in silico mechanism understanding. We found that ketamine can be used to treat cocaine use disorders. So first, we have this AI algorithm. So it's knowledge driven. It's not just data driven, and we use this complicated algorithm to. So basically, this algorithm is very generic. You give any input, say, I want to find the genes associated disease. I want to find the drugs associated with some disease. So this algorithm can predict the drugs or genes for input. So we use this algorithm. First, they say input is cocaine use disorder. You give me a list of drug candidate to treat the cocaine use disorders. So the algorithm predict thousands of candidates. Then we rank those candidates. We present the top 35 to domain experts, like 6 domain experts. So they reviewed the top candidate. The first narrow down one candidate is called ketamine. And then we test the ketamine use because the ketamine is FDA-approved drugs to treat pain, and also people use it for off-count to also for depression. So we use patient electronic health record to evaluate if people taking this drug, people with cocaine use disorder taking this drug for other indication, they just by chance also improve the cocaine use disorders. So we follow the patient for 1 year after they prescribed this medication. We found this drug, ketamine, is really associated with significant improved cocaine and disorder remission in 2 different cohorts. And then we want because we want not just prediction, we really want to figure out the mechanism action. So we did data-driven in silico analysis. We found that this drug is indeed target a lot of genes associated with the disease and the pathways of the disease. So I'm not going to go to the detail. We also predict the genes involved, how special genes involve the which aspect of the disease, and then we validate those in animal model by collaborate with experienced scientists from case, and also we develop AI algorithm to classify group people, like for example, like people with Alzheimer's disease, and which patients have mild cognitive dementia, or people have early stage of Alzheimer's disease or later stage Alzheimer's disease. So we use like imaging data, clinical data, genetic data, demographics to try to build a model for disease diagnosis. And also we build AI model for precision medicine. Basically, for a lot of diseases, highly complicated, heterogeneous. For example, Alzheimer's disease, people can be in the early stage or later stage. Sometimes only some drugs only work better if you're in an early stage. So we develop algorithm can separate the people with the same diagnosis, but into different disease stages. And then we're very interested in AI and the health, environment, and disease. Basically, right now, a lot of diseases, like incidents, are increasing, including cancer, brain disorder. So basically, what we eat, what we breathe in, and like a lot of environmental chemicals can impact our health, including the brain disorders. But using what like animal model to figure out this is very difficult because there are like hundreds of thousands of environmental chemicals. There's no way we can test all of them. But AI algorithm is very good at this because they can very efficient to sort out all kinds of combinations and pinpoint what's the hypothesis, which gene involved, which environmental chemical that target which gene and the pathways, how those impact the different phenotype and diseases. We also work on the develop AI algorithm to figure out how the gut bacteria in our body impact our health, including cancer and brain disorders. So recently, actually, this is I will also talk about the AI for true facts because right now in people the number one risk actually is misinformation and disinformation. And this like a generative AI make this much worse because people can generate mass misinformation, disinformation use generative model just in half an hour or in minutes. So that's very important how we can use AI to count AI generating misinformation and disinformation. So we all know there are a lot of misinformation during the pandemic. So what we did is it's not necessarily AI. We use big data, generate truths about the COVID-19, how the COVID-19 impact the different diseases, how vaccine works, and about the long COVID. So our study actually is already included in the CTSC guidelines. So another recent studies, everybody knows about the weight loss medication, Wegovy and Ozempic. So a lot of misinformation about this drug because it's so new. And so for example, so probably this is not showing. So this we started project based in June last year, 2023. So there are a lot of anecdotal reports say if you take this drug, you're going to have suicide thoughts, you want to kill yourself. So it's kind of there are a lot of information about this drug. So what we did is we just started the project. Actually, is by a high school student. So they use the patient electronic health record and they just check if this drug is really associated, increase the risk for suicide ideations. So this project finished in 3 months, and then we published the paper in Nature Medicine in January 5th. And then 6 days after our publication, so this study is featured in hundreds of news, and 6 days after the publication, the FDA clears this drug of suicide risk. So basically citing our study as a significant contribution to this decision. So what I want to show is why AI can generate a lot of misinformation, disinformation, but we can also leverage big data and AI to generate accurate information to help people make informed decision and help the government to make health policy changes. Basically, our study can be cited a lot of newspapers, so I think it can make big impact. We also do a lot of medical school training in the center right now, probably about 10 or 20. Many students are interested in they publish a lot of papers. They're learning about the AI and the big data, how we can do responsible research based on those new technology and the big data. So yeah, so that's in summary. Basically, we use AI technology. We're trying to work on all aspects of biomedical discovery and research. Yeah, thank you. That's all.
Great. Thank you so much. So maybe I will share the screen back to the slide that had all of the questions that Dr. Kaelber posed. But in the meantime, if anyone has any questions, I think as we move into discussion, it'd be really great if you're able to turn on your camera. That'd be really helpful.
So Dr. Cheng has his hand raised.
Yes. Well, thank you for that very interesting presentation from both of you. As a kind of a novice in this field, really thought about a few things. As clinician, you know the problems are, and you try to find a solution. You want to try to find the right people for solving the problems. Now, AI itself, you have the technical aspect. So the question for you guys are you doing the AI modeling or the technical aspect, or are you more focused on the application of AI technology?
Oh, okay. Maybe I can answer from my aspect. So we heavily focus on AI algorithm development. So because for unless like a prediction model, but if you want to make a discovery, there's no off-shelf algorithm to tell, oh, which gene you can use to predict which gene to involve a disease or drug candidate. So we heavily we develop our own algorithms.
And then I would say for me, I mean, it's really the exact opposite, right? So, I mean, I'm very much in the applied clinical space. So, I'm much more about, I just want to get something working to improve care. So I'm happy to sort of delegate, and it's a different part of AI, right? So in the example that Dr. Zhu gave with helping the FDA, I mean, there was no intervention except just getting the data out there so that the FDA could make a different decision, right? And the things I'm trying to solve, like helping with sepsis, helping with no-shows, making clinicians' lives so they don't have to spend as much time. I mean, that's all about the application of AI in the workflow, some workflow. So to me, I'm sort of happy to delegate, in this case, either to the Epic Corporation or to somebody else, the developing of the algorithm itself. And then I feel like where I and my expertise can come in is how can we really use it to improve an outcome based on the information or the process that the AI is doing.
Well, yeah, that's wonderful. I think this is give you the two spectrum, the two end of the spectrum, application and development. So my follow-up question is, so there are various applications. You can have the workflow optimization, you have clinical decision-making system, you can have others. But for us as clinicians, I think one of the most impactful area is clinical decision making. So how can we leverage the huge amount of information that's collected by our nurses, about fellows, residents, as documents in Epic, and on the one side, and on the other side we have the new and developing and evolving AI technology. How can we leverage both to our benefit, ultimately to the patient's benefit in Northeast or in Ohio?
Yeah, I guess I would say, I mean, I can't agree more. That's where again, my view is we probably have some relatively secret sauce, in Cleveland, because we have the people to actually develop some of the AI, but then we also have amazing healthcare systems to actually implement it. And I would argue, again, particularly for clinicians, you need both, right? I mean, we need people to develop the AI, but then we really need just developing it. And just I won't go into a ton of detail, but sepsis is a perfect example, right? Where there are many ways to implement a sepsis predictive model using the same predictive model. Some of them don't seem to work out well at all. Some of them seem to work out really well. Again, that doesn't have to do with the AI. that has to do with who are you showing the AI to, and what are you asking them to do differently based on that AI prediction. I mean, I see one in the chat. Is it possible for some training for Epic Cosmos? I mean, the short answer is absolutely yes. Again, this was meant to be a teaser. I don't know where this person is, but at this point, Cleveland Clinic, Metro, and UH providers all have access to Cosmos. One of the things we're working on right now is trying to sort of develop some common training on Cosmos, so that it's just more accessible to people. So again, I don't know who this is, but I'd encourage you to either reach out to me if you want, or you're appropriate. You could use our Spark research request hub, be a place to request for some training, or the appropriate research informatics folks at your location. And then you can expect in the coming months that we're going to be developing some sort of universal training, probably put on through the the CTSC website at Case. We've actually talked about probably potentially in the fall having some sort of like a Cosmos hackathon, where we might get people together for an afternoon or over a weekend or something. And for some of our tools, whether it be Cosmos, there's another one called Trinetics, where we could really try to take people from, I just have a little bit of an interest, to really starting to leverage that for some scientific improvements.
And follow-up question about implementation, or how to move the idea to practice. One of the consideration is, so what kind of budget, for instance, for your ICU patient, for your diabetic neuropathy patients, how you make that happen to reduce the surgery rate or amputation rate, etc. So how big a budget do you need to move the needles?
Right. I mean, that's a good question. I guess a couple of responses. I mean, so usually the technologies itself is not too expensive. Usually the expensive part is the people. So when you've looked at this, at least for my, probably you're talking about high 5 digits or low 6 digits. In terms of the people that you need not only to implement but evaluate. Sometimes you have to do sort of a couple of cycles to sort of really get it right. But then I would say two things, right? So first of all, this is where research grant funding can definitely help. And again, to me, a 6-figure grant, right? I mean, those are not super hard to come by, type of thing. And then the other thing, and again, this is sort of where I'm at this nexus, right? So I'll just tell you that for our implementation of sepsis and the no-show model, and even the diabetes model, we did not have any external funding. We funded it internally. Why? Because for the people interested, they didn't see it as research, right? They saw it as, wow, this is an operational problem we really want to solve. And so therefore, they're willing to commit operational dollars, not because they wanted the operational dollars to do research, but because they wanted the operational problem solved. And again, in my world, one of the things I tell people is, what's the difference between an operational project and scholarly activity? It's probably just putting a little bit more attention on the evaluation and then focusing on the dissemination. But probably, 80% of the work or 85% of the work for an operational project versus research, if the research is operationally oriented, right? It's literally like the exact same thing, if that makes sense. So therefore, the added work for evaluation and dissemination, that's probably not 6 figures, that's probably like 5 figures, again, just to sort of speak about it in general terms.
Very helpful, thank you.
I mean, is there anybody? I mean, I feel like, Rong and we're examples of people in this space, again, sort of maybe two ends of the spectrum, but at least I'd be curious that, is there anybody in the audience here that's already doing something or planning to do something in the AI space that we might be able to partner with, or might be of value for the rest of the people here to hear briefly about?
Well, one of the reasons I asked this question in the Cleveland Clinic, our CEO and chief of staff sent a request for application. This is the Mendel Accelerator Grant. So every year dedicate about $2 million for project that help care providers in their supposed care givers in their work to get their burnout, all the things related to the enormous pressure and time consumed on the side of the providers, and also how to improve the patient outcomes. So there are two sides of the same issue. I think this Science Cafe is exactly addressing both problems. I think how we can make it a practical, not just in talking about, actually doing it and making progress. So this, your example is that's so phenomenal. You can really make an application and change the outcome for better. And for Dr. Xu's part, and she developed this not only predictive model, but can generate a new hypothesis and test it, and really gonna make an impact. So all of those is so encouraging that we can kind of put a specific question. For example, not going to take all the oxygen of the group, but this is pain is a huge problem affecting on every aspect of medicine, cardiac, you name it. And if
I would just say briefly, I mean, I'd be happy to follow up with you outside of this, but I mean, if they're putting $2 million on the table, that should be enough to do several of these types of things, particularly if you're leveraging the AI that the Epic Corporation has already spent, yours and my Epic dollars, right, that we're paying to the Epic Corporation. So we're already paying them to develop the AI. So, why not leverage that? But I'd be happy to talk to you outside of this to try to figure out, and Laura Jehi at the clinic, she's very excited about these types of things. So this could be a really neat partnership opportunity here.
Excellent. Thank you.
I see that Heather's hand is raised.
Yeah, I appreciate the talk. This is definitely my niche and my excitement spot. I come from a background as a mid-level military provider, but I specifically work in nonprofit healthcare and research. My professional orientation is to leverage AI ML to provide strategy and execution for innovation in healthcare, whether it's operationally or within research. So happy to throw my hat into the ring as a collaborative partner. I look at things generally through, like I said, through an operational resilience perspective or for a healthcare perspective from a cloud technology kind of orientation. So where we're talking about using Epic and using patient data, there's also a framing of putting that data into a cloud agnostic kind of environment to be able to extrapolate additional data or additional initiatives, benefits from it. So happy to kind of throw that out there as an option as well.
Great, thank you. I think Austin has his hand up.
Hey, yeah, I had a question. I was following up on a previous question, Dr. Kaelber, that you answered, talking about like getting operational kind of funding on an operational basis instead of purely from a research standpoint. And I was wondering for these sort of projects that are, we're currently looking for funding just from a research perspective, if there's some sort of clinical applicability to the specific project or specific research, would you suggest it's generally something to look into, like a good idea to kind of also look for funding from that operational, kind of more of an operational?
Maybe. I mean, I guess I would love to say, again, from being as executive leader at Metro for, almost 15 years now, I would love to say that any clinically oriented research we would love to fund, That's just not the reality, right? It has to be operationally aligned. And what I mean by that is on some level, every clinical, thing is operationalized, but some are much more operationalized than others, right? So like as an example, we just heard Dr. Cheng say, the CEO of the Cleveland Clinic just put $2 million on the table for operational things to help with physician burnout, right? He didn't put it on the table, it doesn't sound like, to help with, diabetes or epilepsy, or, and again, I don't know that whole discussion, so I'm just trying to generalize, right? So I guess my point is it's not good enough that it just might have a clinical impact. If you really want to get operational dollars, it's got to really be tied with where the healthcare system is putting money. And they're not, healthcare systems are not putting money to try to be innovative in every single clinical area that exists. So I think it has to be more nuanced. But to try to make a helpful comment, I would say, if the way to figure that out, because if you're not in a healthcare system, you're not going to know that. The way to figure that out is, if you have an idea that you might think is clinically oriented and might garner operational dollars, I would say, again, you could talk to me at Metro. I could try to get you connected with, some people that might be able to help at the clinic or university hospitals or maybe University of Toledo. So I think somebody has to have the inside knowledge of what is the healthcare system strategically putting money into. So I'll give you another example briefly. We're very much into pay for performance contracts, but they have quality measures that are significantly targeted. So if your idea was going to improve our lead screening rate, we would be all over that, because we literally have hundreds of thousands of dollars in our pay for performance contracts for lead screening. I mean, that's just the way it is. Why isn't it in pediatric obesity? I don't know. The payer said lead screening.
Okay, thank you very much.
Just looking through the chat, I suggest a training class for using AI and Epic. The problem is it's not going to be an hour class. So it depends on the type of AI and Epic. But yeah, again, I know you've sent something else in the chat too. I'd be happy to sort of follow up with you and see if you had particular ideas and how I might be able to connect you up. I see my friend Jacqueline Shea there. We are going to be looking at a sort of a course or curriculum around Cosmos. I will just say too, we are still trying to formalize how to get access to Cosmos at the clinic and UH. We already have a good process at Metro because we've been live for a while. So keep pushing, Jacqueline. If you run into problems, let me know. Talk to Laura Jahi. But we're getting all that worked out. But it's a work in progress as well. Has anybody, I know we got like 8 more minutes. Has anybody thought of one thing that they will do differently based on hearing this talk? We're trying to be an agent of change and an agent of networking.
Now, I have a lot of questions, but in the interest of time, one question. There are some commercial programs or AI tools for patient physician interaction. So during the interaction, you get the information collected, analyzed, and give you a nice record, so you do not have to look at the computer all the time and neglect the patient. So what's in our group, is there something we should be doing, or is there kind of recommended tools we can use to make it a reality, not just I go to a conference, there are a lot of things are being discussed, but what's the thing that makes sense for us to kind of disseminate and to be utilized in this system?
Yeah, I guess it's hard to say. There's so much stuff out there. I mean, I wasn't exactly sure where you're going. I mean, I think the one thing that's still in its early stage is this ambient voice recognition technology, right? So there's this concept that, you know, I would just take my smartphone, lay it down on the table. If I was your patient, you and I would just start talking, and then my note is automatically generated. It's not transcribed, right? Because transcribing, it doesn't, but the AI automatically parses out sort of the fluff from the meat and puts it all together. I would say, again, I've spent a lot of time looking at it. It's almost there, but you know, people have said it's almost there for a long time. But I think that's something I'm going to keep looking at. And I guess I would say, again, for the sake of time, if you're open, Dr. Cheng, if I'm saying it correctly, I would say the one thing I would like to do differently after this meeting, I would like to set up a meeting with you, where we could talk more about all this and really see if there's something that we could work on together. So if you're willing to send me an email, I'm just dkaelber@metrohealth.org or dck3ak. I would love that.
Great.
Lauren?
Hi, I'm Lauren Gerard-Koch. I'm from the University of Toledo, and I'm glad to see Austin was on the call. He's a bioinformatics student, and we just had a lecture this morning about aging and health span. And I was wondering, I just have a general question. Are you using data for example, from all these Fitbit and Apple Watches and things? Are there actually predictors now for things like feeding information so that we can see the health span of individuals rather than always looking for predictors of disease? Are we actually looking at predictors for health and aging, for example? Is that something that in that space as well, rather than looking at it, the health of the patient, rather than and some criteria that would explain that, rather than their predicted outcomes from a disease event or a surgical event or so?
Well, I can make a couple comments. Rong might have some. First of all, I am working with researchers at Case where we are collecting like Fitbit, Apple Watch data. I think we're still trying to figure out like the wheat from the chaff. Right. I mean, so, you know, I've looked at my own heart rate data for years. I'm still not exactly sure what to make of it. Right. I mean, I don't have an arrhythmia, but other than that, like what, you know, where is the real information, knowledge, and wisdom? I'd say the other thing just to think about is, you know, electronic health records and even all these smart devices that you're talking about, they've only been around really for like 5 or 10 years. So I think the problem with that is, to me, where you're really going to start to get information about health span and lifespan is where we have decades worth of data that we can study, right? And the problem is we can't sort of recreate the data in the past. So it's probably going to be decades more that it's going to take till we can really have some insight in that. Because right now what you're doing is you're saying, hey, we've got a couple years worth of data from these things, and we're trying to make extrapolations about lifespan and health span first on just a couple. And of course, those are decade-long processes, but we only have a couple of years worth of data. So I think people are starting to dabble in that area. I think it will take more time because we just need more time to collect the data. I don't know, Rong, do you have anything to add to that? Okay. Mark?
Also, another follow-up question. I'm a preclinical animal modeler. Can we use AI for explanatory or predictive questions rather than hypothesis testing? Let we bring the information already and asking the question. Can the information be revealing of a question from a science researcher point of view? Can it be? Can we feed information in to find causative? If I had like a lot of information, a lot of omic information, can you feed that in rather than asking a hypothetical question? Backwards. Maybe I'm not making sense.
Rong, do you have an answer for that?
So what you're trying to say is,
so if you have a bunch of omics, I mean, if you have a bunch of omic information and you have an animal model and you have a basics for this animal model, could you feed the information in and get patterns, kind of like you do with omic information, but can AI give you information that would be revealing if you were to feed in several like transcriptomics, genomics, metabolomics, and give you new information rather than asking a question?
Yeah, actually, probably that's the AI most good at it because you have data that can find the patterns from the data. And so probably, yeah, that's also part of the generate hypothesis. For example, they integrate all kinds of information. They kind of tell you, oh, there's something going on there. They can tell you, instead you ask, they also can tell you what's something interesting going on here by link all this kind of data. It's not just say, tell you what you expect. They tell you something interesting, not some unusual pattern or insights.
I think we're almost at the top of the hour. Maybe a last question from Mark.
Yep, just 30, very quick. Yeah, thanks. Good talk. So one of the things we didn't cover, which is probably a topic for another whole talk, would be kind of the responsible use of artificial intelligence, that, kind of what are the guardrails that are needed? And there's groups that are addressing this nationally and internationally. And there's several papers that have been written that say, here's the 37 rules that any paper that uses AI needs to follow, including understanding of the data that the AI was used on, understanding the potential biases and things like that. Probably a topic for another science cafe, but I think it's important to keep that in mind, because at a time when insurance companies are using AI models and algorithms to deny coverage based on profit targets, we need to understand what's the motivations, because $2 million, no offense, is a small amount of money compared to the amount of money that's really in the AI space right now. There's billions and billions of dollars being funneled into this. And so just something for a future talk, I think.
Well, I know we're at the top of the hour, so I sort of leave it up to you, Mackenzie, but maybe we stop the recording. Again, I'm happy to stick around if anybody wants to talk to me more, but otherwise I think we thank everybody for attending. Yes, please provide feedback. We want lots and lots of feedback.
Yeah, thank you, everyone. So yeah, there's 3 QR codes. I'll also send a follow-up email, and the links were put into the chat in case you don't have access to hit these QR codes. So the first one is for next month, which is on DEIA. The middle QR code is for feedback. And then the last is if you want to be up to date with becoming a member with the CTSC and all of the events that we have going on in the future. So yeah, if anyone has any more questions, that'd be great. Otherwise, thank you all for attending.